Hello viewers, my name is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing it as well as share it to your near and dears to help them in their preparation of MBBS course as well as other postgraduate entrance examinations. Also, don't forget to press the bell icon below so that you never miss an update from us. Today's topic of discussion is tropical chronic pancreatitis (TCP). It is a unique form of chronic pancreatitis seen mostly in southern India. Tropical chronic pancreatitis is a unique form of chronic pancreatitis. It is seen mostly in southern India. It affects the younger adults from poor socioeconomic strata in developing countries. The etiology is obscure. Possible causes are malnutrition, dietary, familial, and genetic factors, but not alcohol ingestion. The disease causes fast deterioration of endocrine and exocrine function of the pancreas. Cassava or tapioca is consumed in endemic areas as a staple diet by people of poor socioeconomic background. It contains cyanide glycosides that are normally detoxified in the liver by sulfur-containing amino acids. The malnourished population lack these amino acids in their diet. This results in cyanogen toxicity, causing the disease tropical chronic pancreatitis. The cassava toxicity is an important cause because several members of the same cassava eating family are known to suffer from this condition. Environmental factors that increase oxidative stress, such as exposure to certain toxins or a diet low in antioxidants, may contribute to the development of TCP disease. Evidences suggest that there is also a genetic component. SPINK1 and/or CFTR gene mutations are found in 20% to 55% of patients with this tropical pancreatitis. Macroscopically, the pancreas becomes firm and nodular as a result of extensive periductal fibrosis. The pancreatic duct contains large calcium carbonate stones that may resemble a staghorn. There are parenchymal calcifications also. The pancreatic ducts are dilated. Microscopically, there is intralobular, interlobular, and periductal fibrosis with plasma cell and lymphocyte infiltration. There is a high incidence of pancreatic cancer in TCP patients. Patients are usually male from a poor socioeconomic background. They are almost always below the age of 40 years. Patients present with recurrent abdominal pain, either persistent or intermittent pain in the upper abdomen, often radiating to the back. Also, there may be fatty and foul-smelling stools due to malabsorption of fats and weight loss due to malabsorption. The patient has type 1 diabetes mellitus due to the destruction of islet cells. This is known as fibrocalculous pancreatic diabetes. Some present with extreme emaciation and characteristic cyanotic lip. Tropical chronic pancreatitis is classically described as recurrent abdominal pain in childhood, diabetes around puberty, and death in the adult life. The routine blood and urine tests confirm the presence of type 1 diabetes mellitus. Stool tests indicate the presence of fat in the stool or steatorrhea. Serum amylase is usually normal, but in an acute case, it may be elevated. A plain abdominal radiograph and ultrasound show stones in pancreatic duct. CT scanning of the pancreas confirms the diagnosis. Magnetic resonance cholangiopancreatography is useful for visualizing the dilated pancreatic ducts and identifying stones. The ERCP is both diagnostic and therapeutic. The treatment for tropical chronic pancreatitis focuses on managing symptoms, preventing complications, and improving quality of life. The treatment is mainly medical. The main treatment options are pain management, nutritional support, diabetes management, endoscopic procedures, surgery, and regular follow-ups. Endoscopic procedures remove pancreatic duct stones and place a stent to prevent duct obstruction. A side-to-side pancreaticojejunostomy to a roux loop or Pustow procedure is the operation of choice. It consists of a longitudinal incision of the pancreatic duct and implantation of the tail of the pancreas into the roux in Y limb of the jejunum. Partial pancreatic resection is very rarely needed as a last resort.